Well, another welcome to our audience and a welcome and thank you to Dr. Fabian. Dalton Fabian is joining us as a pharmacist and a data scientist who comes with a unique passion for healthcare technology and data science, and not just a passion, but also a practice. He started his experiences in healthcare at Drake University in Des Moines and graduated with his PharmD and a data analytics minor. He also has been working across his interests in data science and healthcare at Unity Point Health, where he'll be actually sharing a little bit of his own perspective and practice today. So Dr. Fabian, thank you for being here with us. I know we have a short walkthrough of what practical data science looks like in slides that I'll be running, but I wanted to ask, just to help orient our audience, can you tell us a little bit about yourself and what your practice looks like so that we can contextualize all that you'll be sharing here in your slides in just a moment?
Yeah, thank you, Robbie. So I'm a 2018 Drake grad. I've kind of always been interested in technology and wanted to do technology as a career in addition to the whole pharmacy and healthcare thing. So my current role is a very good combination of those sorts of skills that I've kind of wanted to build over time. I originally got interested in informatics while I was in school, and kind of through some discovery through preceptors and other connections that I made, I kind of identified data science as something I was most interested in learning about and pursuing more. It was kind of a crazy way that I got into data science specifically. I had asked a preceptor that I was on a rotation with, so my P4 year of rotations, I asked them if they knew anybody in informatics, and they connected me with the husband of a former student who worked at Unity Point as an informaticist. And so went and shadowed him, learned more about his job, was definitely interested in the informatics part. But while I was shadowing him, he told me about the analytics team that existed at Unity Point. So I was interested in that, doing my data analytics minor. Shadowed the analytics department. As I was leaving, they told me, oh, there's a data scientist in the department also. It's like, oh yeah, I should definitely go shadow that person too. And went back, now that's a third time to shadow somebody at Unity Point and learned more about what data science was, especially in healthcare. And then after that, I was pretty convinced that that's what I wanted to do for a career. So that's how I got interested in data science. Then a year and a half later, there was actually a position that opened up on that data scientist team, and now my boss Ben's team. So I definitely took advantage of that. In terms of our organization, so my data science team sits over, or we work with everybody in our health system. We're a central data science team, but a little bit of background on our organization. So Unity Point Health is a pretty large regional health system in the Midwest. So we're primarily based in Iowa, and that's where I live, in West Des Moines, Iowa. But we have hospitals also in Illinois and Wisconsin. So we cover a good amount of ground here in the Midwest and kind of do a little bit of everything. We have clinical projects, work with supply chain teams, as well as even work with some of our HR business partners. So definitely a broad scope of experience that I get to work with on a day-to-day basis.
Thank you for sharing that. And as always, thank you for sharing so much of your journey. Whenever I connect with folks across pharmacy who are either working or interested in healthcare, there are a couple of names that come up as to people who have either interacted with or provided some guidance to these folks who are interested in. Certainly you are one of them in sharing so much of what you have experienced, both the exciting stuff and some of those challenges. And I'm excited to see both of those as you share a little bit in this case and a background to practical data science. And as I share your slides, please feel free to let me know as you'd like to have them advance. And to the audience here, there'll be a pause and a component of interaction for the learners who are attending as a part of the course, where we'll be asking you to debrief on a case. So certainly to anyone in the audience who is joining outside of the school, feel free to share thoughts and comments in the chat. But to our learners who are joining, thanks again on this particular Monday during this week for being a part of the presentation. Feel free to engage at the right time when Dr. Fabian asked about data sources in our machine learning case. With that, I'll turn things back to Dr. Fabian, and hopefully the slides should be sharing here and you'll see data science in real life, and I'll ask you to let me know when to advance.
Yeah, thanks for sharing those slides, Ravi. We had a minor internet catastrophe here, so that's why Ravi is sharing the slides. So yeah, I wanted to walk through what a data science project looks like in real life and walk through some of those skills, both like technical and non-technical, that are needed in data science work. So that if you're interested in pursuing that as a potential career, you kind of know what skill sets and what practical skills you need to be a data scientist or work with data. And I think that's really the best way to talk through some of these skills is going step by step through a project that we completed. I think it becomes much more understandable and more obvious, like how some of those skills interplay into the work that I do. And then we will also talk a little bit about that small pre-work literature review type thing that was sent out for the learners before. We'll get to that in the literature review part of the presentation. You can go ahead and advance, Robbie. So this would have been also sent out for the learners in some of that pre-work, but I wanted to give a little bit of overview of our care management program at UnityPoint, because the tool that I'm going to walk through is the steps in the project that we did for our care management program. So care managers are typically nurses in the clinics who help patients stay healthy day to day. Whereas you might see your PCP once or twice a year, care managers will be in contact with patients daily, weekly, monthly, kind of depending on the needs of the patient. If they're acutely ill, they'll be in contact with them, maybe every day or week, or there might be patients that are doing well and they might talk to them every month, but that's still much more often than the patient might see their other providers. So the goal of the care management program is to enroll patients who are likely to have ED visits or inpatient visits in the future, because the goal of the care management program is to decrease ED visits and inpatient utilization. But where that really gets hard is that UnityPoint has over 1 million active patients. And so even if you're a care manager in a clinic of 10 to 15,000 patients among all of the PCPs in that clinic, how are you going to decide who and what patients need your help the most? It's very hard to do that. So our project that we'll be walking through is how we helped the care management program be able to prioritize those patients. You can go ahead to the next slide. And then when you get to these slides, Robbie, with the thing on the right, you can just click twice on each of them because there's two. So if you click again, there we go. You could just do that for each slide, just advance them to that second one. So, so again, how I've organized this is we'll step through each of the different steps in a data science problem, talk about what we are doing in that step and some of those skills needed for that step. So the first one is identifying the business problem. And here what we're trying to do is get together with whatever program we're working with, the care management program in this example, and try to see how we can help them with data. So for the care management program, we specifically found out that their goal is to enroll patients who are in an accountable care organization who are at risk of having high numbers of ED visits or inpatient visits and get that patient into care management. We do that because ED visits and inpatient visits are expensive encounters. And so since the patients are in accountable care organizations, that's like a care financing type of organization. If we can decrease ED visits and inpatient visits, that's going to save the health system money. So where some of the practical skills and soft skills come in this step of the project, main two here are communication and project management, kind of setting up the project management. So for communication, we as a data science team need to work with the care management program to figure out what they do and understand their program. We had never worked with this group before, so we didn't know the ins and outs of care management. So this is how this communication back and forth and meetings with the team, the care management team, was how we figured out what the care management program's aims were, the fact that they wanted to decrease ED visits and inpatient visits, that kind of stuff. So this is definitely one of the areas where my pharmacy education has helped me the most. Drake put a pretty big emphasis on communication, especially patient communication. I felt like pretty much every week we were practicing those skills in our pharmacy skills class. And so communication was definitely a big part here, making sure we understood how the care management program worked. And then in terms of project management, this is where we had to kind of, along with the communication again, work with the care management program to figure out the scope of the project. We had to figure out, what we were going to try to predict, what tools they needed as the deliverable, what format was this going to come in? Was it going to be a PDF, a dashboard, those types of things. We also had to figure out who should be involved in the program. Was there anybody that were missing? We learned throughout the whole project that the care management program, although pharmacists are not part of the traditional care management team, the MTM team of pharmacists and the care management program work closely together. So we had to involve some of those pharmacists and even social workers that the care management program worked with. And then this was a good way to enable us to, set up a way to track the work that we were going to do in the future, to be on the same page with everybody having some of those project management skills. You can go to the next slide. So this next step in the project after identify the business problem is the literature review. And this is the part I had the learners at least do a little bit of pre-work for, because I think it's a good, easy part of the process to replicate without having access to patient data. So what we were doing here in this part of the project was trying to figure out how other organizations have done what we were trying to do at Unity Point, to use machine learning to predict the risk of a patient to have an ED visit or an inpatient visit. So really what I had to do, and the rest of our team, we had to use skills like being able to comprehend scientific literature, a little bit of curiosity, and have some healthcare domain knowledge and expertise. So in terms of scientific literature comprehension, we had to be able to find articles that matched the environment that we were in at our health systems. So it's important when we were going through articles to identify organizations that looked like ours. This might actually be a good time for the first poll question, especially for the learners. So the first question is, for those of you who completed the pre-assessment type thing, what data source did your review articles used? Was it electronic health records, insurance claims, other, both?
And as the audience is completing that poll for our learners who are completing this case, I'm curious to Dr. Fabian. I wanted to ask, how do you start to scope? Is it a team literature review? Are you doing this on your own and then collaborating with care management as you figure it out? And if that isn't the case, where do you start?
So really the first place we start is from that identify the business problem and figuring out what we want to predict, which was predicting the risk of an ED or inpatient visit in the future. And then after that, this literature review section is, at least for this project, was mostly an internal data science team task, I guess you could say. So what we did was we had, what we were trying to predict. And then at the time there was four of us. Yeah, there's 4 of us on the team. Yeah, 4. And we each went out and tried to find our own articles and see where this had been done before. And then we would come together after a few days and talk about what we found in some of the literature. Using, I think you probably sent this out to the class, using that document, kind of organizing our thoughts and then being able to more or less present what we had found to each other as we were going throughout the literature review.
Great, thanks. And as I share the results, I'll read them aloud. In this case, we had one result for using EHR records, one with just insurance claims, and the majority of which came from both the EHR and insurance claims. One other, which I'm curious, whoever answered other, please feel free to share in the chat where that other came from, either with the group or with me directly, and I'll share it back.
I like to see those results, because that was actually how what our literature review looked like. But really, like in this step, you should find organizations that have data or look like your organization. So traditionally, a hospital or a health system would look for data that, or look for articles that come from another health system or another hospital. And insurance companies, if you work at an insurance company data science team, you'd probably look at literature from another insurance company. And if you think about it, that's because claims data and like hospital EHR based data is very different. You have, I mean, for hospital data, you don't have data if someone uses a competitor to you in town. So there's like two main health systems in Des Moines here. So if they use Mercy, if the patient uses Mercy, you might not have access to those records. You can think about it as an insurance company. If someone has an A1C test done and they are billed for that service, the insurance company most likely doesn't know what the result of that lab test was. They just know one's done, but you could have a patient who has diabetes and the A1C value can tell you a lot about the progression of their diabetes. But if you don't have access to the lab result, then you're kind of in trouble. So a unique thing about Unity Point, though, is that we are in a number of these accountable care organizations that I mentioned before. And through that accountable care organization, we get claims data for our patients, or for a large number of our patients. So we're able to use our electronic health record, which is Epic, and then combine that with claims data and kind of supplement it with claims data to be able to get a more full picture of our patients. And so I'm curious, maybe people can put it in the chat, what types of data points did some of the articles that you went through highlight as some of the most important, or some of the maybe predictors of if somebody was going to have an ED visit or inpatient visit in the future?
And as our learners are taking that moment to reflect the question in the literature that they found, what predictors were identified for those particular studies. And as we buy some time for our learners to share in the chat, which you can either direct message me or share with everyone, what were those predictors that you found in your literature review? I'll ask Dr. Fabian, one of those key questions when you're looking at both EHR data sets and claims data is making sure you're looking at the right patient. How do those things connect, if it's all right to ask, and then go back to some of these points with the predictors that you'd asked about? The question being, how do you connect the clinical data and the claims data if they exist separately?
Yeah, that's a great question. And it's a major issue because there is no patient or like national patient identifier to connect claims data to electronic health record data. And so actually, as part of this project, one of my responsibilities was to create a patient matching algorithm that's still used by my team mostly, but even other teams in our department. So in the whole process, kind of almost a literature review itself, I tried to find some literature on how other organizations have done patient matching before, or just individual matching. And I think it was the Texas Department of Motor Vehicles, or whatever the equivalent is there, had done some work to try to combine patients from like disparate systems. And they found that if you have a patient's full name, their address, birthday, and gender, you could match them like 90, you could match them and get a 95% accuracy rate. And so we modified that a little bit for our work and took a patient's from all of the claims files and Epic and took their first and last name, their gender, their date of birth, and then their zip code. And primarily why we had to do zip code was our claims files only had zip code. They didn't have the full address, so we use zip code. So we made a system that essentially, if a person matched three out of the four of those patient characteristics, they would be considered a match. And then we kind of have a system that sits out there like a database table that has the patient identifier and which claims member ID that patient corresponds to. So that was something that we had to do ourselves that we didn't have previously, or we didn't have the capability to do that previously. So we kind of had made a homegrown solution for it.
It always goes to show there are very few, if easy, answers when it comes to just asking who you're looking for. And some of the comments and predictors that I'm seeing here, both in our chat and what was submitted as a part of discussion in the course, was looking at things like previous versions of department visits and other kinds of visits as they're characterized. Also, which medication and adherence in regards to chronic medication. And something that came up was controlled substances, just as a theme throughout multiple answers. So a bit of a variety between patient factors, clinical history, and things related to medication.
Yeah, those are some good answers in there, or good results that you were finding, because we actually found, so if I was actually able to present without those internet issues, I had a little document that we have that has our most important data points for predicting ED visits and inpatient visits. So when we get to the machine learning point eventually, when you run all this data through a machine learning algorithm, it can spit out at the end which data points are the most important. And so I went in and looked at, specifically for the ED visit one, what were the most important data points that predicted a future ED visit. And the top two were days since the last ED visit and the number of ED visits in the past 12 months. But when I look at some of the other highly predictive features, it's also things like what was their last blood glucose, what was their last calcium value, and I think so it was mentioned in there too, there was a lot of appointment-based metrics at the top, like how many appointments they had been to in the last 12 months, how many appointments they had been late to in the past 12 months. So those were some of the most important data points in predicting these ED visits and inpatients in the future, which it sounds like a lot of people also saw in their literature review, which is good to validate. So we also, so some of these other skills that are on the screen here that we haven't quite talked about yet. Actually, I'll have you go back one slide. Still literature review one. So the curiosity and healthcare domain. The curiosity one is actually an interesting one, and it's kind of related to when you're doing, or when you are doing this literature review, is seeking out new types of information. And I'll share an example that's actually a part of another project, because for the most part, the ED visits and inpatient visits were pretty straightforward. But we, after the care management program, worked on a little bit of hospice information, or worked with our hospice organization on a project. And so when some of us were doing literature review for that, there was a lot of data points on how to predict needs for hospice that include data points that we had never seen before, or that even I, having been trained as a pharmacist, hadn't seen before or wasn't too familiar with. So an example of that was a palliative performance scale, which I hadn't really ever seen before. And so that curiosity part comes in when you see things like that, being able or being curious and doing more research on those things to figure out, how can we get access to this data? Are we collecting this data as an organization? We were seeing other organizations use that data, but we had never touched it before in our organization, at least not in a data science context. So just being able to dig a little bit deeper when you see interesting information come up. And then lastly, the healthcare domain knowledge, having an idea of what is important and what makes up a patient's health. That's a very important skill to have, knowing that there are all of these different lab values and counters, medications, diagnoses, and how those interplay with each other is crucial to the work that we do. And it becomes even more important in the next slide that I'll have you go to. So after we do the literature review, we move on to the data gathering step of the data science lifecycle. So here we are primarily using SQL to get data that we need for the project. And so some skills that come up again here are healthcare domain knowledge. And this is just the ability to differentiate between different healthcare concepts. An example I like to share for this one that my pharmacy training has definitely been helpful in is if I'm looking for a patient's A1C in our database, I might see that it says hemoglobin A1C, and I need to, as a data scientist, be able to differentiate between that and a hemoglobin lab value. You could imagine if someone didn't have any healthcare background, they might not make the connection that those two are actually different things, and they might, for a short amount of time until they figure it out, might confuse those two and conflate those two and save or show hemoglobin values when they really meant to get A1C values. There's also a lot of communication that goes on in this point, again, kind of reiterating some of those pharmacy skills that I feel like make me successful at my position, and how this kind of manifests itself in the data gathering step is working with other parts of our IT department or clinicians to find new data that we haven't worked with before. So especially it's happened a few times in this care management process where I've had to work with some of the informaticists in our organization to find out where new data is. I will need to get a screenshot from a care manager. That might be, this is how I as a care manager do a referral. I want to get that information into the tool. And then I have to share a screenshot with the informaticist and work with them to identify where the data lives inside of our databases. I think in relation to that healthcare domain knowledge is being detail oriented and just paying more attention to those lab descriptions. So I mentioned the hemoglobin versus hemoglobin A1C, but another one where this needing to be detail oriented comes up is when you're looking at, for example, maybe HDL labs. They're in the databases, there are HDL labs, but then there are lab descriptions that have HDL to total cholesterol ratios, and you have to be able to parse apart those details and make sure that you're only grabbing what you mean to be grabbing when you are looking for HDLs, that you're only grabbing HDLs and not different ratios that involve HDL but that are not primarily HDLs. So there's also, in this step, there's also a lot of persistence. I've found that, for example, in most lab queries that we have to write when we're finding A1Cs or HDLs or LDLs, that there might be 5 different codes that represent an A1C. You might have a separate code for a point of care test A1C, a separate code for a traditional lab draw, and there might be other machines that have different lab codes. So you have to be able to find all of those pieces of data. You might, if you only find two of them, you might not have an accurate representation of a patient's health. And then there's also a little bit of technical abilities in this part of the project. This data gathering happens primarily in SQL, or that's the main language that we use in this one. So there is some technical abilities needed in a data science position to be able to take all the data that's in the electronic health record and make use of it. Have you go to the next slide. The next part of the process is our user interviews. And so this is working with our future tool users and figuring out what's important to them. What we found out in this part really was that their previous tools were very scattered. It didn't make them very efficient. They had to look at 3 or 4 different reports and try to marry those reports together to figure out which patients that they should enroll in care management. So a few skills that were particularly important here were empathy and then communication. So when we're talking about empathy, it's being curious about the problems that they're having and wanting to solve them. So like I mentioned, we learned that they were compiling a few different reports to help them figure out who they should enroll in care management. They were looking at who has been discharged in the past few days, who's coming, a separate report for who's coming into the office in the next week or so, who are in these special accountable care organization, that's a whole separate report. And then they also needed to find out what these risk scores of, the risk score being the likelihood that somebody's going to go to the ED or have an inpatient visit, and make sure that they're enrolling the right type of patient who are high risks to go to those types of care settings. We had to go into kind of another way to develop empathy. That the empathy that we found that was successful in this project was actually not just emailing back and forth with them, but going into their office and seeing how they did their work and how they approached their jobs, what the process was like for them enrolling or calling a patient to see if the patient was interested in care management. And then again, a lot of communication in this step. Primarily, it looked like continuing the conversation after we interviewed them, keeping them up to date with our progress, or coming back and asking more questions, and really being able to ask the right questions to them to be able to build a tool that's going to be effective for them in the future. Have you go to the next slide. So then the next step in the process is the data modeling, or AKA machine learning at this step. And we were figuring out how we should build the predictions of how likely somebody is to go to the hospital or have an ED visit in the next 12 months. So in this step, we're getting more into that programming and technical skill set of the data science lifecycle. So we used SQL previously, but now here we're transitioning to using R and Python to go through a bunch of different machine learning models and find the ones that perform the best, or that predict the likelihood of ED visits and inpatient visits the best. So really, the big skills here in this step of the project are definitely the technical abilities. So knowing how to train a model, walking through the machine learning process, understanding how to assess accuracy of a model, and then writing some R and Python scripts to be able to, once the model is determined, being able to actually give patient risk scores in the future. So this step particularly is a very technical part of the life cycle. Have you go to the next one. And then after we have a machine learning model that we're comfortable with and we feel like works well enough, we move on to building a tool with the primary goal here. Again, previously we learned about what makes the current tool inefficient. we need to develop a tool and think about developing a tool that will make the care managers more efficient. And so here we're using data visualization software. In our case, particularly Tableau is the one that we use to implement all of those things that we learned in the user interview to build that one tool that combines all the data points needed so that they don't have to keep going back and forth between different tools. So skills here, there's some data visualization and again, empathy. So the empathy comes in addressing the problems that they had with their old tool. Healthcare professionals don't want to spend time cross-referencing reports and reading reports and all that stuff. They want to take care of patients. And so that's where we can provide them with the most value. And then in terms of the data visualization part, some of those like kind of sub skills that are important are being able to build tools that are intuitive. So usually how we do that in our process is we take what we learned from the user interviews, make a design with the data that we've already gathered in the machine learning model, and take a first stab at trying to figure out how can we present this data to the clinician the best. And so one of us might come up with a visualization, and then we bring it back to our data science team and do some iterations on it to see if other people have better ways to visualize the data. And then we'll also involve the care managers in that process also. Or even there's been a push in our department too to show it to other analysts in our department who don't really know anything about the care management program and see if they feel like the tool is intuitive to use and that it's easy to use. So have we go to the next one. So I did want to share, while I'm talking about building a tool, I did want to share some of our tools so that you can get an idea of kind of how this process works. So this is the Pop Health Toolkit, as we call it. This is the work that we do for our care managers. I'll have you one slide for or one thing forward. Okay. So we learned this tab in general shows the care managers which patients are at high risk of having an ED visit or an inpatient visit. So this is essentially their work list for enrolling patients into care management. So what we learned in our user interviews is actually that care managers, I kind of mentioned it before with the discharge lists that they used to use, they prefer to enroll patients who are currently in the hospital or were recently discharged because they can, in addition to helping the patient over the long term, they can also help the patient from readmitting to the hospital. So we brought all of those patients that were in the hospital or discharged recently to the top of the tool as kind of like the primary patient population that the care managers wanted to work with. Have you go one forward. We also learned that the care managers like to talk to patients in person when they're pitching care management services, which makes sense if any of you have ever done like MTM at a community pharmacy. It's much easier to talk to the person about their medications when they're in the pharmacy rather than giving them a phone call or trying to send them something in the mail. So they like to talk to patients in person rather than over the phone or by mail. And have you go one more forward. And then we also give them a lot of ability to customize the tool. And so I'll just take, for an example, in this one, that middle filter, the registry filter, has a list of a bunch of different medical conditions that patients can have, kind of the big chronic conditions, diabetes, COPD. So if a care manager wanted to specifically focus on patients with diabetes, maybe they were a certified diabetes educator or whatever the new acronym is for CDEs, they could, if they had that sort of expertise, they could filter the list down to only patients with diabetes so that their work can be most effective, or that they can target the most effective use of their time. Have you go to the next slide. this is another one of our tools. I'll have you hit next again. So this tool is a patient appointment no-show. And really what we do, this one's pretty easy to understand. So we predict the likelihood that somebody is not going to show up to their appointment. So the front desk staff at these clinics can give patients extra phone calls to encourage them to come to their appointments. So any appointment in the clinic is inside of this tool, and a front desk staff member at a clinic can go in here and figure out who is most likely to not show up to their appointment. Or the last column there is also predicting which patients might late cancel or cancel within 24 hours of their appointments. Have you go to the next slide and advance two more, or yeah, well, one more now. Yep. So this is our readmission heat map. So what this is probably our most popular project that we have, and it's our 30-day readmission work. So we, this tool essentially, you can see on the first column that's not blurred out, so the fourth column is the likelihood that somebody is going to readmit to the hospital within 30 days. So this tool is primarily used by nurses on the floor, and it helps them with their discharge planning. One of the unique things that we do as an organization, though, is not only predict that 30-day risk of readmission, but predict the risk day by day. On this tool, a gray dot essentially means that the patient is about or has an average risk of readmitting on that day. But if a patient has a pink dot, that means they have a higher than normal or higher than average risk of readmitting for that day. So when you schedule, a nurse schedules follow-ups, that could be phone calls, PCP visits, they want to try scheduling them around those pink dots because those are the times that are most likely that a patient is going to readmit to the hospital. So I have the two different patients highlighted there, and you can see that top red box, most of their pink dots are in the first week. I mean, like 5 out of the first 7 days, I think, are colored pink. So they are very likely to readmit it in that first week after discharge. Whereas you can see that second patient, they have a dot in the first week, a pink dot in the first week, but then they have 3 consecutive days of high risk, about 2.5 weeks out. So both of these patients are probably going to get extra services for them, maybe extra phone calls or extra PCP visits or clinic visits, but the timing of those are going to differ dramatically. That first patient is probably going to get more intensive follow-up in those first few days out of the hospital, where that second patient will probably get that more intensive follow-up about 2 weeks out or so, more around the time that they are at high risk for readmitting. Okay, have you go to next slide. And so the last step in our process is piloting the tool and then launching it. So we'll start with a small group of care managers and have them use our tools, figure out any data issues that are going on. So I think right now our care management program is probably between 40 and 50 care managers. So that's a lot of care managers, but for the pilot, we might choose 1 or 2 per region. And we work with the directors of each region's care management program to figure out who are those engaged care managers that will give good suggestions and things like that. So we work with that group over 3 to 4 weeks and work through any data issues that they see, and then we roll it out to the full program. So again, common themes here for the skills needed: communication and project management are probably some of the most important here. How communication is important here is in that initial, especially that initial pilot period, where we get care managers together to hear about issues that they're having with the tool and making them feel comfortable sharing those things that they're seeing with us. And then as we roll out the program or roll out our tool to the whole program, we also have to have effective communication in telling the care managers what this tool is all about, or the problems that it's going to solve for them, so that they feel comfortable using the tool. Because really, a clinician will only use a tool and will only use your tool heavily if they feel comfortable with all of the data that's inside of it, and that they understand where it's all coming from. And then the communication part two honestly involves kind of prolonged communication, I'll call it. So even 2+ years later, after the rollout of this project, I still do a ton of work on it, but I also go to care manager meetings, like regional care manager meetings, and tell them about some of the new stuff that's in the tools or new features that have been rolled out recently to keep them updated over time. And then the project management part of the pilot and launch is just organizing all of the fixes that we need, especially in the pilot part where we're identifying some of those issues, is organizing all of those issues that they're seeing and really asking probing questions to get more specifics, so that we can have a complete list of all the problems that they're seeing, and ways to kind of go figure out what is the source of those problems. So it's asking them to, like, oh, you say that you're not taking care of this patient anymore, but the tool is showing that you are. Can you show us how you thought that you were unenrolling yourself from the patient? Things like that, getting them to show you in Epic. Oh yeah, you're not on the care team anymore. Why is it showing that you still are on our end? And we work through some of those problems with the care managers. For project management, we also have to focus on how we update the tools over time. The care management program work takes up a pretty significant portion of my time even now. So we had to come up with a sort of process on how to get new features approved, like who has the sign off to be able to, or who has the ability to ask us to put new features in, and who has to approve it for that to actually go into the tool. And then if you hit next, that should be the end. So as you can see, there's a ton of different skills, and some of those skills are repeated over and over again and are important in different ways in different parts of the projects. But those are some of the main practical skills that you need for just working with data in general, or having a career in data science.
Well, thank you for that fantastic overview. Certainly rare insight, and honestly some rare work. And I come with only a limited perspective compared to what you've seen in practice, but looking at as many broad scopes of implementations in data science, many times you're stuck at validation, meaning what an ROC curve looks like, rather than actually talking to end users. So to hear that you're really assessing the tools and translations in practice really makes me think, as pharmacists, the difference between efficacy and effectiveness when it comes to applications of data science. I had a couple of great questions here in the chat, and I'll certainly invite more as we go on. And before I do so, Dr. Fabian, any other kind of thoughts or comments before I jump into a couple of questions? And to everyone, I invite questions in the chat. You're welcome to either share with the whole group or send direct messages.
That ROC curve type thing that you mentioned made me think of something else too, on just like how important communication is as part of my work. So if the audience out there knows about a decent amount about machine learning, there are so many nowadays, like crazy algorithms that you can do, like crazy complex algorithms that you can do or use. But what we found over time is really that we'd rather spend more time on talking to our users and making them more comfortable with the tools than trying to eke out like another percentage point of accuracy on our models. So we, by like machine learning standards, we use pretty tame machine learning methods. So most of our stuff are, for anyone familiar, are random forests. which are, I guess, far less complex than some of like the neural networks that are around and easily implementable these days. But we've really just found it more impactful to spend time talking with our users and getting them comfortable with the tools than trying to get, that extra little bit of performance from the models.
Great. Well, a couple of questions that came up throughout the presentation. I do see a hand raised from a participant. From the presentation, one question that came up was in regards to roles and how what you described gets parted out. And I know that's kind of organization specific. And then the second question, which I'll highlight first, is when you're using literature resources, what's the scope of the literature? Is it usually peer assessed studies, or are you looking at other components or examples in practice, things like commercially available databases or anything related to regulations?
That's a good question. We traditionally stick to the types of like peer-reviewed research unless some of those like commercially available databases. That's not something we really do. That's that second one. It's more of the traditional like going into PubMed and searching machine learning emergency room visits, stuff like that, more than like paying for outside data sources, if that answers the question.
And the other question, when it comes to data points, or at least roles and responsibilities, how do you balance, or what's the nature of the literature review as one skill set example? Is it you personally going out to do the searches and to find the data itself? Or you mentioned it was a team approach. Does it get handed off, or in any way heavier emphasis on the analytics team when it comes to the actual stats? Or does it depend project to project? So who's doing what, I suppose, is summary of that question.
Yeah, so it's definitely just our data science team kind of itself is doing the research. So we usually don't in that step of the process involve, at least in the care management work, we didn't involve like any other analytics teams, or we didn't need to necessarily work with, we work with the care management program and many other things, but not necessarily in the literature review. So we each went out, the four of us on the team, and found our own articles and filled out a sheet that had information like, or allowed you to document like what types of patients were they working with, what data points did they use to predict the risk of an ED visit or an inpatient visit, where you could jot down like this study used A1C and number of ED visits in the past 12 months. And then what we did was when we came back together, each of us had that sheet filled out with all of the different data points that other studies have used. We had a Word document open and just had a running list of all of the different data points that other people had used. So there was definitely a lot of overlap. Like any research study probably that is looking at the risk of ED visits is probably going to have some form of the number of ED visits in the past 12 months. That's probably going to be in every single article. So that's going to get repeated a lot. And that tells you something also. But we just go through, our whole list and compile that into one big list and kind of use that in that data gathering section after literature review. That's then what we go out and go find in our electronic health record. So go find all of how to get the number of ED visits in the past, or get somebody's last A1C value or last blood pressure. That's kind of how the process will work. So we each go do our own, out of the four of us, each go do our own research and then get back together and kind of create a one big list of what we found so that we can parse through it a little bit better.
As we wrap the hour, there's still a couple of unanswered questions. If Dr. Fabian, you have a moment to stick around after for anyone who has those extra questions. This short one, hopefully short one, that I can end on is, do you find yourself using more R or Python currently? I'll definitely add in SQL as well, and then we'll wrap at the top of the hour here.
So if it's between SQL, Python, and R, one thing I found interesting is the actual machine learning process of it and programming in R and Python is far less than I would have imagined. So out of all the programming I do, it's probably 85% SQL. So SQL is definitely an important skill that you should learn, especially if you're going to work in healthcare data science, because all of the data that's input into electronic health record is saved in databases, and which SQL is the primary language to get data out of relational databases. So by far, SQL is the most important language that I use. And then in terms of the R versus Python thing, we historically have used more R than we have Python. We're actually implementing some cloud computing capabilities right now. And so we're kind of in between. We're going to switch to using Python more because of some just technology requirements that we have to follow. But historically have used much more of R when compared to Python. So I'm most comfortable in R at the moment. Although I don't mind Python. I do like Python, and that's kind of where my first taste of machine learning in school, my data analytics minor, was in Python. So that's kind of where I started at.
As I wrap and say thank you again, and certainly for anyone who has any questions, I'll end the recording in just a second. But Dr. Fabian, anything we can do back? So many thanks to you in regards to your time, your presentation this afternoon. Where can people either find you, follow you, or is there a resource or connection that you'd prefer or something that we can offer back?
Yeah, if anyone wants to connect with me, probably the best place is on LinkedIn. I feel like I'm pretty active on there, sharing different data science specific things or any resources that are available. That's probably the best way. Just feel free to send me a connection request on LinkedIn.
Great. And I'll certainly add, there's a ASHP webinar that is archived and available for access from Dr. Fabian. And I believe you'll be speaking at a couple of upcoming conferences, and I'm looking forward to hopefully getting a chance to say hello in person.
Yeah.
So if everyone will join me in a virtual round of applause and reaction, or as you clap in front of your webcam, thanks again. And if anyone has any questions, feel free to stick around.